you look at the morphology over here, this is the diagram as you can appreciate over here. So what we see very importantly on the right hand side, we can appreciate that there is fat necrosis. And over here you can see that this is the area where you can see the fat necrosis, and over here you can see that there is a process of saponification which is giving a bluish tinge to the degenerating surviving fat cells, as we can appreciate. Secondly, we can see over here, now first I will show you, these are the islets, okay, as we can appreciate this is the pancreatic islets, okay. Then what are these? This part, this is the pancreatic acinus which is the exocrine part, and this part is the islet which is the endocrine part. And over here we can see the engorged blood vessels also. Over here we can see the engorged blood vessel. Also what you can appreciate over here, this portion, as you can appreciate, these are the ducts, okay. These are the ducts. Ducts are basically carrying the secretions of the acinus. Okay, now what you can appreciate over here in the middle part, as you can appreciate, this is the middle part. What you can see that there is necrosis of the acinus, there is necrosis of the ducts, okay, there is a necrosis of the blood vessels leading to hemorrhage. So there is a characteristic pancreatic parenchymal inflammation and necrosis. So necrosis of the acinar cells, necrosis of the ducts is there. To some extent necrosis of the pancreatic islets is there, and very important, you can see the presence of acute inflammatory cells. So you can see the presence of excessive amount of neutrophils over here, okay. So there is excessive amount of acute inflammatory cells that is present. So these are the most important features. So what we are seeing fat necrosis, we are seeing pancreatic parenchymal inflammation characterized by necrosis. Not only that, we are also seeing the hemorrhage over here. We are also seeing the intraparenchymal hemorrhage as well. So these are all the features characterizing acute pancreatitis. Myself, Dr. JIBRAN Ahmad, presents to you Simply Pathology, and today we are back with a very important lecture. In today's topic of discussion, we are going to read about pancreatitis, both acute as well as chronic, okay. Now this topic is very important, not only for the postgraduate students, but it is also very important for the undergraduate MBBS students. Why? Because this topic will be asked to you not only in pathology, but you will also be asked about this topic in your surgery, and you will also have a long case in your exam. You may have a long case of pancreatitis as well. So pay a lot of attention for today's topic of discussion. So before I start my discussion, let me just ask you one question. So this is a very important question. It has come several times. Such type of questions are asked very commonly right now in in your NEET exams, as well as in your exams of from the institutes of national importance, that is INI exams, as well as these clinical vignettes are being asked in your MBBS exams as well. So let me just take you through this history, okay, first, and later on, after we read our topic, we will come back to the question to solve the question in hand. So a 47-year-old obese woman, okay, presents with severe abdominal pain which is radiating to the back, okay. So this is a very important history, radiating to the back. Now there is no history of alcohol or even drug abuse. Now the blood pressure is falling approximately 90 by 45 millimeters mercury. Respiration is becoming more 32 per minute. And pulse is 100 per minute. So what are these signs? These are signs of shock. Patient is going into shock. The physical examination is showing abdominal tenderness, guarding and rigidity. An X-ray film of the chest is showing a left-sided pleural effusion. Now laboratory studies reveal elevated serum amylase to the tune of 850 units per liter and serum lipase to the tune of 675 units per liter, as well as there is hypocalcemia. So which of the following is the most likely diagnosis? So first we are going to read, then we are going to come back to this particular question in hand. So basically we start with the pancreatitis. So as I have already explained that pancreatitis can either be acute or it can be chronic. Pancreatitis is initiated by the injuries leading to auto-digestion of the pancreas by its own enzymes. Now normally there are certain protective factors, okay, which is preventing auto-digestion of the pancreas, or which is protecting the pancreas. So just like in the GI tract, okay, in the stomach, there are certain protective factors which is preventing any kind of injury to the stomach. Similarly, in the pancreas, there are certain protective factors under normal conditions which are protecting the pancreas. So most of the digestive enzymes of the pancreas it is synthesized as inactive proenzymes, also called as zymogen. Okay. Now remember, under the effect of trypsin, which is released by duodenal enteropeptidase, which is also called as enterokinase. So under the influence of enterokinase, okay, they are stimulating the trypsin, and this trypsin is converting this pancreatic proenzyme, pro means which is an inactive form, into active form. Okay. So the pancreatic proenzymes, they are converted into active enzymes with the help of trypsin, which itself is activated by duodenal enterokinase or enteropeptidase. Okay. Now, so therefore we see that most of the digestive enzymes in the pancreas, they are normally inactive. Only when we are having some food, okay, only when food is entering the duodenum, that duodenal enterokinase is released, which is stimulating the trypsin, which is then converting the inactive enzymes in the pancreas into active enzymes. So there is a process that follows. So the enzymes are not getting activated by itself. Therefore, we can say that the intrapancreatic activation of the proenzyme is normally minimal. So normally it is not in the active state. Only when food is there, that enterokinase will be released, that is going to stimulate the trypsin to convert these inactive enzymes into active enzymes. Okay. Remember, normally the acinar and the ductal cells, they secrete trypsin inhibitors, okay, which are serine protease inhibitor casal type 1, also called as PINK1. So normally also remember that the pancreas, it is having an exocrine part, it is having an endocrine part. So if you remember, the exocrine part is composed of the acinus, which is secreting the enzymes, and there is a ductal system which is carrying these digestive enzymes. Okay. So normal conditions, when there is no food, okay, remember the acinus as well as the ductal cells are secreting trypsin inhibitors, so that the trypsin remains in the inhibited form and the enzymes are not activated. Okay. Pancreatitis will occur when these protective mechanisms are disrupted or when they are overwhelmed. Okay. So this is the basics of the pancreatitis. Okay. So now we are first going to start with acute pancreatitis. Okay. So let us start with acute pancreatitis. Now, acute pancreatitis is basically characterized by a reversible, so very important, it is a reversible condition, okay, reversible pancreatic parenchymal injury and inflammation, and it is multifactorial. There are many causes which can lead to acute pancreatitis. So biliary tract disease and alcoholism alone account for approximately 80% of the cases of acute pancreatitis. Now the male to female ratio is 6:1, so 6:1 in alcoholics and 1:3 in biliary tract disease. Okay. Now gallstone is present in 35 to 60% of acute pancreatitis cases. Now gallstone induced pancreatitis is present in approximately 5% of the patients with gallstones. Okay. Now let us look at the etiopathogenesis of acute pancreatitis. So first of all, we will look at what are the etiologies. So the first etiology that we are going to see is metabolic. So alcoholism, hyperlipoproteinemia, hypercalcemia may be secondary to hyperparathyroidism. The ingestion of certain drugs like azathioprine, statins, GLP-1 agonist and DPP-4 inhibitors. Okay. So all these are the metabolic causes which can lead to acute pancreatitis. Then there are certain genetic causes which we will read in details. So mutations in certain genes like PRSS1 or SPINK1 or CASR or CFTR gene, they can lead to acute pancreatitis, or they might precipitate an attack of acute pancreatitis. Then there might be certain mechanical causes which are basically leading to obstruction, okay, like the presence of gallstones or trauma, okay, any kind of trauma or iatrogenic injury. For example, injury is there during operation or during carrying out any endoscopic procedure like ERCP, or any vascular causes which is causing ischemic acinar injury like shock, atherosclerosis, embolism, vasculitis like polyarteritis nodosa. So all these are vascular causes leading to ischemic acinar cell injury precipitating acute pancreatitis. Then infections like mumps, Coxsackie virus, they can directly cause acinar cell injury and lead to acute pancreatitis. So these are the 5 most important causes of acute pancreatitis: metabolic, genetic, mechanical, vascular and infectious causes. Okay. Now we are going to read about the pathogenesis of acute pancreatitis. Okay. So pay a lot of attention over here. So acute pancreatitis occurs because of an inappropriate release and activation of pancreatic enzymes that in turn is going to destroy the pancreatic tissue and elicit an acute inflammatory reaction. So we know that in the normal condition, the trypsin is kept in the inhibited form with the help of certain trypsin inhibitors released by the acinar cells as well as the ductal cell that we have already read about. Okay, so basically excessive stimulation and activation of the trypsin is going to stimulate and is going to convert the proenzymes and will activate the proenzymes and make them active. Okay, they make them active. Okay, so these proenzymes, what are these proenzymes? These are prophospholipase and proelastase. So this prophospholipase will convert into an active phospholipase which is going to act on the fat cells, leading to fat necrosis. Similarly, the proelastase, okay, they are going to act on the elastic fibers of the blood vessels, okay, as well. So once the tissue damage commences, okay, once the tissue damage starts, the trypsin not only it is not only converting the proenzymes into active enzymes, but they are also the trypsin is also going to stimulate certain factors in the blood, thus releasing the clotting factors and also activating the complement system. Okay, and this is causing small vessel thrombosis. Okay, it is activating the small vessel thrombosis. So three very important factors are involved in the pathogenesis of acute pancreatitis. So what are those factors? Number one, pancreatic duct obstruction. Number two, primary acinar cell injury. And thirdly, defective intracellular transport of proenzymes within the acinar cell. So we are going to see each one of these factors individually, and then we are going to see what happens in the end. So the number one factor that we will see is the duct obstruction. So gallstone and biliary sludge, or any periampullary neoplasms, okay, which is obstructing the ampulla of Vater, or the presence of choledococcyl, that is the congenital dilatation of the CBD duct, okay, or the presence of parasites like Ascaris lumbricoides and Clonorchis sinensis, or a congenital condition like pancreatic dehiscence. So all these conditions are creating obstruction of the duct of the pancreas, thus raising the intrapancreatic ductal pressure, and which leads to interstitial edema. So unlike the other enzymes which are inhibited, remember the pancreatic lipase enzyme, it is secreted in the active form itself, and that leads to what is called as fat necrosis. Now when the fat is undergoing necrosis, they are also releasing certain danger signals which are sensed by the nearby pancreatic stellate cells as well as the acute inflammatory cells like the leukocytes. So they are sensing the danger signals which are released by the necrosis of the fat, okay, and that is leading to their activation and they release. So these inflammatory cells and these stellate cells, they cause the release of more pro-inflammatory mediators, which further exacerbates the condition, causing more interstitial edema, okay, and ultimately causing acinar cell injury. Okay, so this is the first mechanism, that is the duct obstruction leading to a raised pancreatic intraductal pressure leading to interstitial edema. So when an edema is there, they are going to compress the blood vessels, causing further ischemia and acinar cell injury. Not only that, this edema is also, not only this edema is also going to lead to what is called as fat necrosis, and whenever fat necrosis will occur, they are going to release more amount of danger signals, and these danger signals will stimulate the inflammatory cells like the leukocyte, which will release more mediators of inflammation. And once the mediators of inflammation is there, that they are going to damage the endothelial cells, causing further edema, and that is going to further compromise the flow of blood, leading to more acinar cell injury. So this is the number one mechanism, that is the duct obstruction. The second important mechanism of acute pancreatitis or the pathogenesis is the primary acinar cell injury, like alcohol or any kind of drug or trauma or ischemia or viruses or hypercalcemia. So all these cause primary acinar cell injury. So how do they do that? They cause the release of intracellular proenzymes as well as lysosomal hydrolysis. So how does this release of intracellular proenzymes and lysosomal hydrolysis, what they do, they cause acinar cell injury, because all these digestive enzymes, okay, they should not be released inside the pancreas. They should become active, where the food is present, in the gastrointestinal tract. But such kinds of alcohol, drug, trauma, ischemia, viruses, hypercalcemia, all of them, they can activate this enzyme within the pancreas, leading to acinar cell injury. How? Because there will be pancreatic autodigestion. So not only that, so what happens that whenever such kind of a stress or whenever such kind of exposure to alcohol, drug, trauma is there, then there is oxidative stress. How? Because they facilitate the release of free radicals, and the free radicals, they lead to lipid peroxidation as well as transcription factor activation like the AP1 and NF-kappa beta. Now these transcription factors, they are pro-inflammatory in nature, and they further increase the inflammatory cycle. Now always remember that hypercalcemia or increased calcium levels are always precipitating acute pancreatitis. How is it possible? Remember, whenever there is increased amount of calcium, okay, they are causing trypsin auto activation. They auto activate the trypsin, and you all remember that once the trypsin is active, they are going to convert the proenzymes into active enzymes. Whereas when there is a decreased amount of serum calcium, then the trypsin is itself cleaved and it inactivates. So always remember, whenever in the question in the exam you are seeing hypercalcemia, in that case always remember that it is precipitating acute pancreatitis, okay, and ultimately leading to acinar cell injury. The third important mechanism over here is defective intracellular transport of proenzymes within the acinar cell. Now, normally remember, the digestive enzymes and the lysosomal hydrolases, they are separately transported. They are not transported and they are not in contact with each other. But whenever there is acinar cell injury, whenever the acinar cell injury is there, remember, the hydrolases, that is the lysosomal hydrolases, they are aberrantly delivered to the lysosomes, which activates the pancreatic proenzyme. So normally the lysosomal hydrolases, they do not come in contact with the pancreatic proenzymes, but in conditions of acinar injury, this lysosomal hydrolases, they are transported to the lysosomes in a very defective manner, in such a way that they come in contact with the pancreatic proenzymes and they activate them. Okay, and what happens that this activates the pancreatic proenzymes, which digest or the lysosomal membrane, and they release all the enzymes within the lysosomes, leading to pancreatic autodigestion and acinar cell injury. Okay, so in all these conditions, all these three things leads to activation of the pancreatic enzymes within the pancreas, leading to edema. So how the edema occurs, we have already explained. It is a part of inflammation. Increased duct obstruction, they can lead to interstitial edema, they will lead to proteolysis, they will lead to fat necrosis, because all the digestive enzymes are released, so they will digest the proteins, they will digest the fat. Not only that, also elastase is released, which will damage the blood vessel wall, leading to hemorrhage as well. Ultimately, all these things will give rise to acute pancreatitis. So in your exams, you have to write like this only, and this will fetch you full 100% marks in the exam. Okay, now I would like to just add few extra points with regards to alcohol induced pancreatitis. Now the two important points in alcohol induced pancreatitis is duct obstruction as well as acinar cell damage. This is similar to what we have discussed previously right now. So when you are consuming alcohol, so transiently it is going to increase the contraction of the sphincter of Oddi at the papilla of Vater. So as a result, that is going to cause obstruction at the level of the pancreatic ducts. Chronic alcoholism leads to secretion of protein-rich pancreatic fluid, which inspissates as a protein plug. So if this is the pancreatic duct, some amount of fluid is released, protein-rich pancreatic fluid is released inside a duct, which inspissate and which will create protein plugs, and that is going to obstruct the small pancreatic ducts, thus increasing the pressure and leading to interstitial edema. Again, there will be cycle of inflammation precipitating acute pancreatitis. Now, in the acinar cells, remember, alcohol, not only that, it is acting as a toxin. So it is causing oxidative stress by the release of free radicals, that is stimulating certain transcription factors like the AP1 and NF-kappa beta, which is further stimulating more inflammation, and it is causing release of more inflammatory mediators. Not only that, alcohol also facilitates the fusion of lysosome and zymogen granules, that is the pancreatic proenzymes. Okay, so once they combine with each other, they are going to actually lysosomal hydrolases will activate this pancreatic proenzymes, and these proenzymes will digest the lysosomal membranes. They will come out and they will cause pancreatic autodigestion. Not only that, the alcohol also increases the intracellular calcium level. All these things will ultimately stimulate the trypsin, activate the trypsin, which will convert the pancreatic proenzymes into the activated enzymes. Okay, so I hope this point is clear to everyone. Alcohol is acting in all these ways that we have already discussed before. Okay. Now, what is hereditary pancreatitis? So you might get a short note on hereditary pancreatitis. Okay. So over here, the affected individual, they have recurrent attacks of severe acute pancreatitis, which is often beginning in childhood, and ultimately these individuals, they suffer from chronic pancreatitis. So what are some of the genes involved and what is their role in causing pancreatitis? So let us understand. So the number one gene is PRSS1 gene. So if there is mutation over here, so remember, most of the hereditary cases of acute pancreatitis are occurring because of gain of function mutation in PRSS1 gene, which is also known as trypsinogen gene. So what does it do? That it makes, so the products of the PRSS1 gene, they make the trypsin resistant to self-inactivation. Now normally the trypsin self-inactivates, okay. So they are making the trypsin resistant to self-inactivation. So trypsin is always active, or they will make the trypsin prone to proteolytic activation, or the trypsin by itself is becoming active. So there is a gain of function mutation of PRSS1 is leading to activation of trypsin more commonly by itself, okay. Now individuals which are having mutations over here do so by an autosomal dominant mode of inheritance with a gain of function mutation, and such individuals not only they suffer from acute pancreatitis, but they also have a 40% risk of developing pancreatic carcinoma. Again, a very important MCQ, okay. The second type of gene involved is PINK1 gene. So normally they are encoding a trypsin inhibitor. So if there is a loss of function mutation of this gene, that is going to lead to excessive trypsin activity and precipitation of acute pancreatitis. And these individuals, they have an autosomal recessive mode of inheritance, okay. So by this we are able to separate both of them. Then CFTR gene, loss of CFTR leads to abnormal secretion that causes protein obstruction, plugging and duct obstruction. Okay, so mutation in the CFTR, or individuals suffering from CFTR or cystic fibrosis, again they suffer from acute pancreatitis. Now mutations in CASR gene, that is calcium sensing receptor. So mutations over here may alter the calcium levels and activate the trypsin. Then CTRC, so mutations in the chymotrypsin C gene. So normally it degrades the trypsin. So and protects the pancreas from trypsin related injury. So if there is a mutation in this particular gene, again they will precipitate acute pancreatitis. And again the last gene is the CPA1 or carboxypeptidase. So mutation over here can also precipitate hereditary pancreatitis. So you should remember all these 6 names if you are asked about the concept of hereditary pancreatitis. Next we are going to read the morphology. So remember, the morphology of acute pancreatitis might range from limited inflammation and edema to extensive necrosis as well as hemorrhage. So what are some of the key important features of acute pancreatitis? So where we are having microvascular leak and edema because of inflammation or release of inflammatory mediators. Those enzymes that are releasing, they will digest the fat, leading to fat necrosis. Now once the fat necrosis occurs, the fatty acid will be released that will combine with the calcium, that will lead to what is known as saponification. There will be presence of acute inflammation, neutrophils will be present, okay. Once the enzymes are released, they will cause auto-digestion of the pancreas, the pancreatic acinar cells, okay, or the acinus, which is releasing the exocrine enzymes, okay. So they will be digested, and that will be depicted by the presence of necrosis. So spotty necrosis or sometimes extensive necrosis might be seen. Then because these enzymes are also acting on the elastic fibers of the blood vessels, so they will lead to blood vessel destruction as well as interstitial hemorrhage. Now fat necrosis is stimulated by lipase activity. Remember, fat necrosis is stimulated by pancreatic lipase activity. So basically these will act on the fat and they will cause release of fatty acid. These fatty acids will combine with calcium to form insoluble calcium soaps, and this process is called as saponification. So under the microscope, this saponification appears as bluish microscopic appearance, okay, to the surviving fat cells. So what are some of the microscopic appearances? You can get acute interstitial pancreatitis characterized by mild inflammation, okay, interstitial edema and focal fat necrosis. Then you can have acute necrotizing pancreatitis characterized by necrosis of acinar ducts as well as to some extent the islets. Then we have acute hemorrhagic pancreatitis, which is the most severe form, which is characterized by extensive parenchymal necrosis, intraparenchymal hemorrhage as well as fat necrosis characterized by the presence of chalky white yellowish deposits. Now in the peritoneal cavity, you might see serous slightly turbid brown tinged fluid with fat globules. Okay. So if you look at the morphology over here, this is the diagram as you can appreciate over here. So what we see very importantly on the right hand side, we can appreciate that there is fat necrosis. And over here you can see that this is the area where you can see the fat necrosis, and over here you can see that there is a process of saponification which is giving a bluish tinge to the degenerating surviving fat cells, as we can appreciate. Secondly, we can see over here, now first I will show you, these are the islets, okay, as we can appreciate this is the pancreatic islets, okay. Then what are these? This part, this is the pancreatic acinus, which is the exocrine part, and this part is the islet, which is the endocrine part. And over here we can see the engorged blood vessels. Also over here we can see the engorged blood vessel. Also what you can appreciate over here, this portion, as you can appreciate, these are the ducts, okay. These are the ducts. Ducts are basically carrying the secretions of the asanas. Okay, now what you can appreciate over here in the middle part, as you can appreciate, this is the middle part. What you can see that there is necrosis of the asanas, there is necrosis of the ducts. Okay, there is a necrosis of the blood vessels leading to hemorrhage. So there is a characteristic pancreatic parenchymal inflammation and necrosis. So necrosis of the asanar cells, necrosis of the ducts is there. To some extent, necrosis of the pancreatic islets is there, and very important, you can see the presence of acute inflammatory cells. So you can see the presence of excessive amount of neutrophils over here. Okay, so there is excessive amount of acute inflammatory cells that is present. So these are the most important features. So what we are seeing fat necrosis, we are seeing pancreatic parenchymal inflammation characterized by necrosis. Not only that, we are also seeing the hemorrhage over here. We are also seeing the intraparenchymal hemorrhage as well. So these are all the features characterizing acute pancreatitis. Coming to the clinical features of acute pancreatitis, so abdominal pain, very important, constant intense pain which